our previous lecture on the same topic. Okay, so previously we have covered on the common urgent ocular conditions. Okay, what are the red flags, the key red flags, and what is urgent care? And we have also covered on the eye examinations. Okay, and then we continue to the transient visual symptoms. Okay, the transient visual symptoms. So what are they? So basically, transient visual symptoms will involve macula, so several macular disorders, and also CSC, central serous choroidopathy, which will resolve completely within 6 weeks to 6 months. So in this case, you have to monitor the conditions of the CSC or CSR. Okay, and then idiopathic stellate neuroretinopathy, okay, and acute multifocal punctate pigment epitheliopathy, AMPPE. This will also resolve in few weeks. Okay, but usually these conditions will have to be monitored with OCT. Okay, all right. And then for ARMD and angiostrix, if they have a transient visual symptoms, usually it will also resolve in few weeks as well. Okay, so for this condition, okay, even they have the underlying ocular diseases, okay, even if they have the underlying primary disease or ocular disease, okay, if they have these transient visual symptoms, these symptoms will be resolved within weeks, okay, and the vision usually will improve even with the condition or the underlying cause, okay, but of course, ultimately you have to mention to patient that this condition will primarily lead to permanent visual loss. Okay, so if a patient is having macular edema causing by a solar burn after eclipse watching or sun gazing, okay, they will also experience a surprising transient visual loss, but the recovery of vision also will follow suit. Okay, and then severe and especially sudden systemic disorders, particularly by hypertension. Okay, so hypertension can cause transient visual loss. Okay, it can be idiopathic without reasons, eclampsia, okay, pregnancy related, or severe metabolic imbalance such as acute renal failure. Okay, so these all conditions may cause temporary visual loss, okay, which causing by the macular edema or secondary retinal detachment. So this condition will persist until the primary condition is cured. Okay. So blunt trauma to the head is less likely to cause visual loss. Okay, usually direct trauma to the eye and the orbit can cause brain injury, especially to the occipital cortex. Okay, and then it can also damage the contricute optic nerve and lead to retinal damage as well. Okay, optic nerve contusion can also be causing by high dose systemic steroids. Okay, so if patient is having transients or temporary visual loss, you have to ask patients if they are under steroid. Okay, IV lah, by IV, systemic steroids. Okay, for blunt injury, it may cause visual loss. Okay, ranging from severe lid edema to optic nerve avulsion and includes orbital fractures, ocular hemorrhage, cataracts, and also retinal damage. So if anyone is having blunt trauma, it may or may not causing visual loss. Okay. So the complications is the eyelid edema, okay, lead to optic nerve avulsion. So have to check if there is any fractures on the orbits. Have to check fundus if there is any ocular hemorrhages. Okay, this blunt injury also can lead to cataract because of the crystalline lens rupture. Okay, and of course, it will also lead to the retinal damage. So if you receive a patient with blunt injury, you have to check the vision. You have to check the fundus as well, and also slit lamp to check if there is any perforations on the crystalline lens. Okay. Okay, so pupillary examination is very important for any injury, for any urgent care. So you have to check on the afferent pupillary defect. You have to do Marcus gun, okay, because this is very helpful in determining damage to the visual pathway, okay. So like I mentioned on the previous lecture, CT scan and MRI is necessary if you suspected patient is having orbital fractures and also optic nerve and brain damage. Okay, so orbital fractures usually if you try to touch the orbit, right, to touch on the side of the face, they will complain pain. Okay. All right, so severe direct trauma on the eye will cause ocular perforations. Okay, means the eye will be bocho lah. Perforate is bocho, okay? And then severe hypotony, okay, means there is a blood accumulations or pus accumulations inside the anterior chamber, chemosis, and of course, visual loss, okay? Ocular perforations, like I mentioned again, if the steel is from silver, okay, it can enter the eye. It can enter the eye, especially when the patient is doing some hammering on the metal object. Okay, so silver is fine, so it can perforate easily to the cornea. So you have to be careful. Okay, post-surgery visual loss also can happen after surgery. Okay, it can happen by several obvious ocular complications such as hyphema. Okay, such as hyphema. Okay. Right, so ocular or orbital surgery can cause orbital hemorrhage, optic nerve damage, ocular perforations, and intravascular injection during retrobulbar anesthesia must be considered. So if the surgeon is doing ocular or orbital surgery, okay, causing by the hemorrhage or optic nerve damage or ocular perforation, anesthesia must be administered before and during the surgery lah, because of the pain. Okay. Spontaneous idiopathic persistent visual loss, when bilateral, most often results from non-ocular disease. If there is any sudden, okay, spontaneous or sudden idiopathic with no reasons, patient is healthy, no trauma, basically all fine, okay, and the visual loss are persistent, maybe more than 6 hours, persist more than 6 hours, and it happens on both eyes, okay, it happens on both eyes. Usually you can rule out the condition as non-ocular. So it's not related to the ocular disease, like it can be something else, systemic disease or neuro-related. Okay. All right. So all cases of visual loss should be considered eye emergencies until the examination indicate otherwise. So any patient who needs our urgent ocular care and is having visual loss, you have to consider that case as eye emergency. Okay. And severe monocular visual loss in the elderly. Okay, severe monocular, one eye visual loss in the elderly. So in the elderly is 65 and above, considered as the geriatric age lah. Geriatric age is 65 and above. Okay, so this you have to take note if the patient is having any temporal arteritis. Okay, you can see that at the sides of the forehead, is there any how to say is there any visible vessels that is that you can see at the side of the forehead? Okay, so this condition of temporal or cranial arteritis usually has to be treated by steroid. Okay, and then toxic visual loss is usually bilateral. So we have discussed this as well. What kind of toxic visual loss, right? Okay. So for transient visual loss, first the temporal profile of the transient event. Okay, the temporal profile of the transient event. What are the primary causes? That's why history taking is very important. And then usually for transient visual loss, the fundus examination when you check is usually normal. Okay, for transient visual loss, you can expect that the fundus is normal. Okay, so patients who experience visual loss when they look to one side usually have an intraorbital mass that compresses or stretches the optic nerve as it moves with the rotations of the eye. So patient with visual loss, okay, when they try to look at one side, okay, usually will have an intraorbital mass. So this mass basically compress or stretch the optic nerve as it moves with the rotations of the eye. That's why they have transient visual loss. There is a temporal mass expected orbital or temporal mass that compress or stretch the optic nerve that causing the transient visual loss. So when they look straight, the vision is okay. When they look at the temporal side, then they will experience visual loss because of the compressing and stretching of the optic nerve causing by the intraorbital mass. Okay. When you do eye examination, it can be normal, okay, or there may be evidence of a mild optic neuropathy in the form of an afferent pupil defect. So your pupil test might be abnormal, okay, and then you have to also check on the color desaturations and also the fundus to see if there is any disc edema. Okay, optic disc edema, basically you can see a blur margin area lah. The margin will be blur. You cannot see, basically you cannot determine the border of the cup or the disc. Okay, transient obscurations of vision in 50% of patients with papular edema secondary to intracranial hypertension. So transient loss of vision will usually happen in 50% of patients, okay, with papillo or papular edema, okay, causing by intracranial hypertension. So if the patient is hypertension, you have to check if patient is having papilloedema, and then usually the transient visual loss will happen in 50% of patients. So you can basically counsel or advise or manage patients in such a way to let them have the idea of this transient visual loss. Okay. Right, so vision is lost usually in one eye, just long enough for the patient to be aware of it. Okay, so usually if they have the vision loss, they will be aware, they will be conscious, and they will try to blink a few times or rub the eye. Okay, they're like confirm whether they like to confirm whether the vision loss is still there or not. So they will try to rub, they will try to blink few times. Okay. But then if it's happened again and again and again, frequent, okay, so usually the patient will have to consult a physician, okay, or they might come to us, optometrists, so we have to advise accordingly, okay. And also you have to check whether, again, patient is having any illness. Hypertension is the main cause, okay. So any condition resulting in tightly packed nerve fibers as they enter the disc to form the optic nerve may produce similar symptoms, okay? You know where is the area that the nerve fibers is most tight or most in numbers? When the optic nerve, the nerve fibers need to go through the optic disc, right? And then they have to go before they enter our brain, okay? So where is the location where you can say that it is a bundle of nerve? Hello? Is anyone there?
Yeah.
Yeah. So where
Yeah.
is actually the bundle of nerves located?
Optic nerve.
Tribunal smallest.
Hmm?
Optic nerve.
So actually the cup. Okay? The cup
Yeah,
is actually our bundle of nerves where the nerves enter the optic disc to the brain. Okay. Okay, amaurosis fugax is a very brief or very prolonged episode of transient visual loss. Okay, it can be caused by carotid arteriosclerotic disease. Okay, carotid arteriosclerotic disease is cerebrovascular disease related to the heart. Okay, related to the heart. But the likelihood of carotid occlusive lesions is much smaller. So usually amaurosis fugax is related to the heart, okay, which can cause transient visual loss, okay, but it can also caused by the carotid occlusive lesions. Okay, it's just two different conditions are related to the heart. One is atherosclerotic, one is occlusive. Okay. So risk factors, again, hypertension, coronary artery disease, peripheral vascular disease, family history has to be taken into consideration. So if they have a family history of heart disease, cerebrovascular related, so you have to take note. If they have an incidence of amaurosis fugax. Amaurosis fugax ni, if we call it in Malay, it's like you pitam. You know what is pitam, right? You like black out for a while. Okay. All right, so migraine, the presence of small visual loss, okay? Patient will experience with a small visual loss or mild disturbance of vision that progressively increases over 15 minutes or more. So basically, migraine can also lead to visual loss, okay? Small one, okay? Or mild disturbance of vision, but it will increase, okay? The frequency of the visual loss will increase over 15 minutes or more. Okay, so usually if you notice patients, migraine patients, they have, how to say, they basically like to just let the eye closed. Okay, they'll just sleep, or then they try to avoid any glare or light. Okay. So symptoms, fortification spectra around an area of scotoma or distortions. Okay, so they can see like a glariness. Okay, they can see a scotoma. Okay, visual loss, and around the scotoma they can see like a glariness or distortions. Okay. Transient monocular visual loss. Okay, if fundus is normal, a patient have transient monocular, one eye visual loss. Fundus normal, age 40 and below. So you can suspect patient is having carotid occlusive disease. So just now I mentioned that there are two conditions that can cause amaurosis fugax. First is carotid atherosclerotic disease. First is carotid atherosclerotic disease, main one. But if the patient is young, so you can suspect patients of having carotid occlusive lesions. Okay. All right. So transient visual loss, it can associate with first migraine, Raynaud's phenomenon. Okay, diseases. This Raynaud's phenomenon is diseases causing basically increased viscosity of the blood and from cardiogenic embolism. Okay, there's an emboli in the heart. This can cause transient visual loss. Okay, the most associated conditions of transient visual loss. Okay. Next is distorted visions or metamorphopsia. Distorted visions or metamorphopsia. So the patient usually doesn't know. Okay, if patient have this distorted vision, usually they will not aware whether it is binocular or monocular, or if it is associated with other symptoms. They'll just mention that my vision is, they won't mention distorted lah. Usually patient will come with complaint of blur vision. Okay. Usually patients, okay, if they have distorted vision, metamorphopsia, or any kind of jaggery vision, right? They will just mention I have a blur vision. That's all. Okay, very general. So we have to figure out what kind of visual loss they are having. Okay. So you have to check for distortions one eye at a time. So it is easily done using the Amsler grid. Okay, Amsler grids is very important to have in your practice. So this Amsler grid will test central 20 degrees of vision at reading distance. Okay, so basically Amsler grid will test our reading lah. Okay, our reading, near vision. Right? And large vitreous floaters, okay, if patient is having vitreous detachment, it will also interfere with vision, especially at close range, and it can mimic monocular distortions. So patient, if they have vitreous detachment, okay, you can also put it as differential diagnosis because it can mimic the monocular distortions, right? So halos around lights with or without blurring of vision may indicate glaucoma. Okay, so if patient comes to you and complain of halos around lights, okay, basically differential diagnosis can also be glaucoma apart from astigmatism. I think usually commonly a patient complain of halos around lights, you will think of, oh, astigmatism. Okay, but it is not. It can also indicate glaucoma. So we have to investigate further. Okay, diplopia or triplopia. Okay, diplopia, double vision, or triplopia, triple vision. It has to be investigated initially with a careful examination of muscle balance. So, kind of test that you do to check on the muscle balance. Anyone?
Our test.
EOM. EOM, correct. Okay. Have you experienced patients with triplopia? Triple vision. So one image instead of double, they said they see three.
No experience before.
No, right? It's actually very rare to happen lah. Okay. So next, okay, if you encounter a patient with acquired, okay, sudden nystagmus, straight away refer to neuro. Okay, acquired nystagmus. Even if the patient is children or adult, acquired means like they are having it after the congenital age lah, after 6-year-old or after 4-year-old. Okay, so straight away refer to neuro. Binocular dysmetrosopia. Okay, binocular dysmetrosopia. What is binocular dysmetrosopia? Anyone? Can you Google what is dysmetrosopia? What is dysmetrosopia? Anyone?
Retina image disparity.
Retina image disparity. Okay. Any others?
Anisoconia. Same.
And isoconia. Okay. It's like a different appearing of objects, right? Okay.
Yeah.
Anyone else?
Which object are perceived to be smaller than the actual?
Correct. Okay. Any others? What is the syndrome related with this dysmetrosopia?
Retina edema.
No. Okay, we call it as Todd syndrome. Todd apostrophe S. Todd syndrome or Alice in Wonderland syndrome. Okay, so basically people with this syndrome, they experience distortions in their visual perceptions of objects. Just now your friend have mentioned, object is appearing smaller. It can appear smaller as than the usual size. It can appear smaller or larger than the usual size, okay? Or appearing to be closer or farther. Okay, it can be appearing close or far than the real distance. Okay, that is dysmetrosopia. Okay, usually it is retinal origin, but of course it is related to the brain lah, cerebral. Okay, so cerebral sorry.
Why it has so fancy name, Alice in the Wonderland syndrome?
Yeah, I don't know. So it's a neurological disorder. The term is from neuro. Alice in Wonderland. Yeah, you're right. I'm also like, when I first reading about this syndrome, I was like, wow, such a nice name. Alice in Wonderland. Okay. The last statement, yeah. Cerebral micropsia may be associated with migraine, epilepsy, hysteria, schizo, drug intoxications, and focal lesions. Okay, now please Google what is micropsia, cerebral micropsia. What is micropsia?
Micropsia, it's appearing image in smaller size.
Correct, micro lah. Okay, micro. Cerebral micropsia. So it can be associated with migraine, epilepsy. Okay, you know what is epilepsy, right? Hysteria, schizo, drug intoxications, and also focal lesions. Okay. All right. So these are the summary of the the symptom and the possible causes. So I've already put in a table for you for exam purposes. So please read and memorize this table. Right? Do I need to go it one by one? Let's just go one by one, okay? Sudden loss of vision. Sudden loss of vision can cause by retinal detachment, optic neuritis, stroke, central retinal artery or vein occlusion. Flashes of light can be caused by retinal tear or detachment. Floaters, okay, floaters, sudden increase of floaters. So when patient comes to your clinic, right? When they complain floaters, you have to ask whether there is an increase there is an increment of floaters numbers lah. And you have to also ask what kind of floaters looks like. Are they opaque or are they transparent? Okay. So you have to basically ask properly if it's related to floaters. So because we have to consider vitreous hemorrhage or retinal tear. So visual field loss can be caused by glaucoma, stroke, pituitary tumor, and retinal disease. Distorted vision, metamorphopsia, ARMD, and also edema, macular edema. And then double vision, diplopia, it has to be muscle related. Okay, you have to check the eye muscle lah, either EOM lah for preliminary test, and then for further test, you have also to check if needed for prism cover test and check the PFB and also NFB. And then eye pain with vision changes, you can suspect patient is having acute angle closure glaucoma, optic neuritis, and orbital cellulitis. Okay. Red eye with vision loss, uveitis, keratitis, endophthalmitis. So this endophthalmitis usually will happen after cataract surgery. So you have to take note on this as well. Halos around lights, corneal edema, acute glaucoma, color vision changes, optic neuritis, toxics or nutritional optic neuropathy, and then gradual central vision loss. Okay, gradual means the vision loss is getting worse. Okay, so you can suspect of macular degeneration in RMD or diabetic macular edema. Okay, so triage or quick decision guide. First, vision loss, is vision loss present or not? Okay, is it painful or painless? If it's pain, you have to grade. Okay, ask patient to grade the pain. Okay, is there any photophobia or discharge? Okay, photophobia or discharge. So discharge, you have to ask whether it's mucus or watery. And then history of trauma or chemical exposure. Okay, I think this is quite obvious for you to ask. Any neurological symptom? This is quite general lah. Okay, questions that you can ask, example, like just now, okay, micropsia or macropsia. So you can ask patients, maybe you put one object at the front of patients and ask patient to grab the image, to grab the object, or ask patient to guess the distance of the object lah, to confirm any neurological symptoms. Also, you can also do red desaturation test. You have to do, okay, the most important one is pupil test. Okay, yes, so you have to check on the pupil reaction. Okay, and then is there any form hallucinations? Okay, if you suspected any hallucinations on patients, so you can rule out the temporal lobe involvement. Okay, because the temporal side of our brain is usually related to the visual perceptions. Unformed hallucination. What is the difference form and unformed hallucination? Form is basically hallucinations of objects. Unformed is other than that lah. Unformed hallucination is other than that. Unformed hallucination example, they said something is there when it is not. Okay, so that is kind of unformed hallucinations. Formed hallucinations is that they may see an object of orange, but they maybe they tell you it is an apple, example. Okay, so that are the difference of formed and unformed hallucinations. Okay, all right, poor color vision. The evaluations of color vision complaints is important primarily because poor color vision may be an early sign of acquired disease. Okay, so if there is a change of color visions, you can suspect patient is having acquired ocular disease, and it can help you differentiate any other differential diagnosis. Okay. Occasionally, color vision evaluation is needed in the certification of personnel for occupation. Okay, This one is for work purposes lah, for work purposes, okay? Right? And usually for color vision evaluations for work or occupation purposes, if the patient is failing the test, usually it's congenital. Okay, acquired is they get it suddenly. Okay, they get it suddenly. So acquired color vision defect usually will affect the blue yellow. Okay, and the visual pathway for the blue cone signal is thought to be because why they affected the blue yellow pathway, because the blue cone signals is thought to be more vulnerable to diseases and ocular insults than the pathway to red or green cone signals. Okay, because for photoreceptors for cones we have several. We have three types. So these three types, one of the cones is responsible for the blue signals. Okay. Okay, poor night vision. The patient history for night vision problem is notoriously unreliable. Okay, even in cases of very reduced dark adapted sensitivity. So usually patient might not notice the decreased night vision, okay, because it's night time. So usually they will assume that okay, nighttime is nighttime, no light, that's why I cannot see. So that's why the usually patient will not complain lah. Okay. So these complaints of visual problems at night usually related to depressed cone rather than rod. Okay. We know that rod is responsible for scotopic. Okay, but usually the vision problems at night is causing by the depressed cone. Okay, because sufficiently dim ambition illumination is rarely encountered in developed countries. Okay, so basically many complaints of vision problems at night are related to depressed cone rather than rod sensitivity because sufficiently dim ambient illumination is rarely encountered in developed countries. Okay. Wait, let me digest. What does it mean by sufficiently dim ambient illumination is rarely encountered in developed countries? Okay, basically in developed countries, there will be more lights. Okay, in developed countries, there will be more light. So there's no such an issue of dim light or dim illumination. Okay, so and this complaint will usually happening at developed countries because of this issue. Okay, so these are the three conditions that causing poor night vision. First is fundus albipunctus or Gucci disease and retinitis pigmentosa. Okay, so far any question that you would like to ask?
The hallucination is caused by the normally mental vision, isn't it?
Hallucination. The formed and unformed hallucination, is it? This one.
Form and unformed.
So your question is?
Normally those have this one, normally they got mental problem.
Not necessarily. Not necessarily they have mental issue. They can, yes, you are right. Some of the patient will have mental illness, but some of the patient is not. Okay, basically they might be influenced by medications. Okay, they might also influenced by
Drugs, by alcohol.
drugs, toxicity. They might also causing by any growth on the visual pathway. Okay, basically on the temporal lobe of the occipital lobe lah. They can have some tumor example. Okay, which can lead to this hallucination.
So what's
So
the
they
difference between form
sorry?
and unformed? One is occipital, one is temporal lobe. Can we
Yeah,
one
is
form one at the side, occipital lobe is near to the brain or what?
Where is the occipital lobe? Do you know or not? Where is it?
I don't know.
Occipital is at the back of our head. When you touch your neck, above your neck, that is our occipital.
Oh,
Okay. Temporal is the side. Temporal is side. When you touch your ear, above your ear, that is temporal lobe.
okay, okay.
Okay. So form hallucination is basically more realistic. Okay, just now I mentioned, right? Form hallucination is like they see an object, they see people. Sorry, I terbalik. Form hallucination. Hold on now. Okay, let me re-explain this again. I terbalik. Okay. Form hallucination is more complex as in they hallucinate something is not there. Unformed is more simple hallucination. Okay, more defined like colors, objects. Okay, so just now I mentioned terbalik lah. So form is basically something, they hallucinate something that is not there. Unformed, they hallucinate a simple hallucination. So they basically still different light, different colors than what we see. Okay. I hope I am making it clear. Okay, Stephen, am I answering your question?
Yeah. Thank you.
Okay. All right. So now we are going to go through this flow chart on what we are going to do on. Okay. If patient is having visual loss, okay, if patient is having visual loss, okay, first you have to check, okay, any temporal history or not, okay, any temporal history, any trauma on the head, okay, and then you have to ask patient whether it is transient or persistent, okay. If it's transient visual loss, you have to check the retina, okay. Check the retina. If it's normal, okay, you can consider it is neuro-related lah, or acute glaucoma. So you have to check IRP. If the retina is abnormal, so you can see vitreous hemorrhage, retinal vascular occlusions, macular disorders, or any systemic conditions. You have to ask patient if they are having any health issues or not. If the vision loss is persistent, okay, you have to ask more questions. You have to probe more questions to the patients, okay? And you have to see if they are having any traumatic injury. So if it's because of trauma, straight away refer for CT, MRI. And if patient just having a surgery, after surgery, then you have to consider referring them back to the surgeons. If it's spontaneous visual loss, okay, if there's no abnormality, then you can suspect patient might have toxicity. Okay, malingering lah. Malingering means patient is just playing around. Or hysteria. Hysteria is hysterical blindness lah. They actually can see, but because of psychological issue, they can have that. We call it as hysterical blindness. They blind just for a while, okay? And if there is abnormality found, so you have to treat the abnormality or refer to the related physician. Okay. So patient with transient visual loss, just now we have to check the temporal profile of visual loss. Okay. The temporal profile of visual loss. If it's occurring only with eccentric eye position, just now I mentioned, only one gaze, okay, such as basically usually at the temporal side, okay, you can suspect of orbital mass lah. So straight away refer for CT scan or MRI. If transient visual loss is less than 60 seconds, okay, less than 60 seconds, check fundus and rule out papilloedema, okay, or patient is having any disc drusen, okay, congenital disc drusen, not drusen on the macula, it's on the disc, okay. So if drusen on the disc, you can try to Google and see how it looks like, okay. And then if the fundus is normal, you can suspect of amaurosis fugax. Amaurosis fugax related to the heart, okay, cerebrovascular related. And then onset with progressive increase in visual loss over 15 to 30 minutes. Okay, first it's transient. After that, the frequency is increased 15 to 30 minutes. Then you have to ask patient whether got headache or not. If got headache, you can rule out migraine. So migraine need further neurologic evaluations and management lah. If no headache, then you can suspect patient to have normal eye examination. Basically, VA, everything is normal. So you can rule out patient as esophageal migraine. Esophageal migraine, non-neuro related. Okay. If the transient visual loss is happening at 5 to 60 minutes, 5 to 60 minutes. If it's binocular, then you can suspect patient is having stroke attack. Okay, transient visual loss happening 5 to 60 minutes. Binocular, so you have to straight away refer to stroke unit or emergency unit. Okay, but I would suggest you, if you suspect patient is having transient ischemic attack, you can straight away refer to stroke unit. So basically in Klang Valley, the nearest stroke unit we have is PPUM. And then further up we have Selayang. And then we have HKL. Okay, the rest is emergency. They don't have stroke unit. Why we need to refer to stroke units? Because it is faster. So the management of patient is faster. Any treatment also fast. Don't need to wait. Okay, because stroke, the most important thing is timing, management, the timing of the management or any treatment required. Okay. And then if private, I think private, the best stroke unit will be Sunway lah, Sunway Medical Center. Okay. And then if it's monocular also, you can suspect of amaurosis fugax. Okay. And then you have to check the fundus. Okay, if it's abnormal or not. Okay, if it's abnormal, then we have to treat accordingly lah. If there is any emboli or retinal edema, so we have to evaluate for the carotid lah. Okay, carotid for central retinal carotid, CRAO. Okay, CRAO. So then again need neuro treatment lah. Okay, if the transient visual loss is happening 1 to 24 hours, 1 to 24 hours, usually it is idiopathic. Okay, it is idiopathic related to amaurosis fugax. Okay.
What is amaurosis fugax?
Amaurosis fugax ni macam you black out. You black out for a while. Like you pitam. Have you experienced that? Usually causing by low. Sorry?
Idiopathic ni?
Hmm?
Idiopathic, atypical, what that?
Idiopathic. Idiopathic means no cause.
No cause.
Atypical is common amaurosis fugax. Means there's no reasons. There's no reasons of There's no reasons of causing the transient visual loss lah. Okay, so we rule out it as idiopathic atypical emeresis fugax. Sorry, atypical non-common, sorry. Idiopathic, atypical non-common emeresis fugax. All right.
So it's more serious that one.
This one is like we don't know why. There's no reason underlying the transient visual loss. So we rule out as this emeresis fugax. But then again, there's a paper saying that emeresis fugax very much more like a symptom before patient is having, it's like a mini stroke. A mini stroke. Okay. But it's not in the book lah, so it's in a paper. I'm just sharing lah. It can be right, it can be wrong because
Can share the paper to us.
yeah, can. I will send to you after the lecture, okay?
Thank you, thank you.
Okay, page vision, history of distorted vision, you have to check with Emsler chart, okay? So distorted vision, it can be pseudo, it can be true, okay? It can be pseudo, it can be true. For pseudo distortion, okay, you have to do a thorough eye examination, check visual field, check muscle, check also neuro pupil test, and see if there is any decreased vision. Okay, if decreased vision, then manage accordingly lah. Optical disturbances, floaters, halos, dissented intraocular lens. Okay, this one you have to check if the intraocular lens is not in place or not. Okay, and then visual field abnormalities can caused by central scotoma or hemianopsia. Abnormal eye movement, diplopia, tryptopia, nystagmus, neurologic problems, binocular dysmetropsia and polynopsia, and then hallucination lah. Okay, this will be causing pseudo distortion. And then metamorphopsia, okay, can cause by macropsia. Okay, micropsia, if monocular, can be causing by edema. So these are the considerations of macular edema. If binocular, it can be binocular excludes pseudo distortion. So it is actually metamorphopsia lah. Okay, micropsia, if it's monocular, it can be caused by macular wrinkling. Okay, idiopathic, you can consider conditions of idiopathic macular pucker, epiretinal membrane, macular scar, causing by inflammations or trauma. And then irregular distortion can cause by epiretinal membrane, idiopathic macular pucker, impending macular hole, and then vitromacular tractions be empty. Okay, so if irregular distortion, patient need to be referred to ophthalm for vitrectomy. Okay, so basically for metamorphopsia, you have micropsia, macropsia, and irregular distortions lah. So we manage accordingly. Okay. All right, poor color vision. Okay, poor color vision. First is color agnosia. This is brain related. Okay, brain related agnosia, anomia, aphasia. Okay, and then defect in color sense. Okay, first abnormal color discrimination or matches. Usually it's the blue-yellow defect or achromatopsia. Okay, achromatopsia can be caused by cone degenerations and rod monochromacy, cone monochromacy or cortical color blindness. Okay, And then visual scenery appears tinted with color. Color of objects appear desaturated. Okay, this one is all also neuro-related lah. Like mentioned in the lecture just now, blue-yellow defects. Blue-yellow defect is the common condition for poor color vision. Okay. Okay, difficulty seeing it. Sorry,
Is
sorry.
common or not? Achromatopsia.
Not common. Achromatopsia not common. Not common. Usually, if it's caused by midbrain injury lah, cortical which
What
can
injury?
cortical color blindness. Sorry?
Cortical
Sorry, Steven?
injury. Caused by cortical injury. Just now you mentioned the achromatopsia.
Yeah, cortex injury to cortex.
I mean the brain, the back brain, isn't it?
Sorry?
Caused by the cortex, the injury, trauma caused by.
The location yes. Yeah.
Miss, I
Our
think your
retina,
line is
okay?
jerking.
Checking. Hello. Can you hear me now?
Yeah, can. Just now was jerking, not very clear on your explanation.
Okay. So basically, color vision is also responsible by the cortex, the visual cortex at the back, occipital area. Okay. So not only on the retina itself, the processing is up to the higher processing area, which is the cortex. So if there is any injury or growth or tumor on the cortex, okay, which disturbing the color pathway, then it can lead to cortical color blindness. Okay. Okay, patient with difficulty seeing at night. Okay, first, of course, history, and then you have to do dark adaptation tests. Okay, if it's normal, okay, you can do ERG. Okay, ERG is electroretinogram. It is ERG is a visual diagnostic instrument which only available in the hospital. Okay, electroretinogram. So you can, if patient is having this difficulty at night, basically what we can cannot be tested with a normal eye examination that we have in the clinic. Refer ERG. If ERG is normal, patient might have consideration. If ERG is abnormal, then we can suspect of patchy retinal abnormality. If dark adaptation abnormal, ERG normal, visual pathway can be a defect. If it's abnormal, you can generalize as choroid and retina abnormality. Okay. And if the difficulty is stationary, okay, then you can consider this disease. Means the difficulty see at night, the grade of severity is just the same throughout, then you can consider it as stationary. If the difficulty seeing at night is getting worse, then you can consider these three diseases or conditions lah: retinitis pigmentosa, cone rod degenerations, and then metabolic or systemic disease and toxicities. Okay. Okay, patient with isolated diplopia. Patient with isolated diplopia, it can be monocular. Okay, monocular images. Okay, there is a ghost images. Mean there is a shadow lah. Basically, you can suspect of this lah, refraction, vitreous and iris abnormalities. If the image, there's several images. Or refer neuro. If binocular, okay, there's a strabismus, then it can be a decompensated congenital phoria or divergent paralysis, means BV related lah. If concomitant strabismus, you have to see if there's any proptosis or not, means the eye is like bulging or not, because to rule out thyroid. If there's no proptosis, then you can see if there's any weakness of muscles. Okay, check further for any palsy. Okay, tensilon positive is for myasthenia gravis. For no proptosis, basically, if you see this pathway, it's all muscle related lah. It's all muscle related. Okay. And then other neurologic symptoms or signs, you can suspect of intracranial disease. So again, neuro consultations, right? Okay, patients with photophobia, you have to ask them the onset, okay, the onset, whether it's since birth or early life, okay, because you want to rule out congenital conditions, albinism and iridia, loss of iris, congenital glaucoma. And if the anterior segment is normal, you can suspect of achromatopsia or cone disease. At onset, there is an injury, so patient experience photophobia. So you have to check the fundus, the cornea as well. Okay, and see any average or if there's any trauma, whether you need to basically manage further or refer further or not. And then spontaneous onset just suddenly happen, you can suspect of toxicity. Okay, but first you need to check on the slit lamp. Okay, check whether it's normal or not. If it's not, if it's abnormal on the anterior, if the anterior is normal, you check posterior. Okay, if the posterior is also normal, then you can suspect of this lah. Okay, this is normal posterior, this is abnormal lah. So abnormal, basically papulitis, uveitis, posterior uveitis, posterior scleritis. Okay, flashes and floaters. Okay, flashes only. It can be pseudo, it can be true. If it's true, then you can you have to check retina. Okay, check on the retina. If the flashes and flows together, you have to see whether it's like chronic or acute suddenly happen, or it's already there for a long time. So if it suddenly happen, you have to ask whether the patient have to count the number of floaters lah. Basically less than 12 or more than 12. If more than 12, usually we have to again refer patient lah. And if it's already disturbing patients and also their VA. Okay, if it's floaters only, then you have to ask whether it's progressive, again, progressive or chronic. And if it's progressive, more and more floaters, then we have to refer for biopsy lah. Okay, if it's chronic and stable, usually we will advise and monitor first and inform patient what are the risks of the floaters, which is posterior vitreous detachment and also opacities lah. Okay, so initial assessment start first. You need to check VA, and then you have to assess the pupil and eye movements, pupil, chest, and also EOM. Fluorescence stain is a must in your practice. You need to have fluorescence. And then do not apply pressure to injured eyes. If you see any injury eyes, try not to touch, apply pressure, check IOP. Okay, anything pressuring the eye, please avoid. Okay, unless you want to ask patient whether it's pain or not, you can ask patient to touch by themselves, or you can touch lightly or gently on the patient's orbit. Okay, and then if avoid treating unless trained. So of course on our side, what we have a few steps that we can do lah. Okay, which I will explain later. Okay, so urgent referral criteria. When you need to refer urgently first, any vision loss, any sudden vision loss, refer. Rate painful with decreased vision, refer. Suspected globe rupture or foreign body, refer. Neurological signs, visual field loss, diplopia, triplopia, refer. Chemical injuries, please irrigate first, then refer. Okay? The irrigation is very important for any chemical injuries because it will make a difference on patient's cornea. Okay? Urgent ocular care essentials, of course, you have to recognize red flags early. Okay, you have to see what kind of red flags of the urgent ocular care. And then you have to perform basic eye exam, acuity, pupils, EUMs. Refer urgently if vision, structure, or neurologic signs are affected. Okay, vision affected, structure affected, neurologic, there are neuroscience. Okay, then refer. Timely action can preserve vision and prevent complications. Okay. Okay, so let's watch a video on how we can do irrigation on patient with chemical injury. Okay, sorry, not this one. Irrigation for October.
Irrigation and swinging is the same, isn't it?
Sorry, somebody is talking.
Irrigation and swinging is the same.
Eye irrigation.
Yeah.
Irrigation first.
It's same.
Irrigation and stringing. I don't think it's the same. Let's watch this one first. How they do the irrigation, okay? Can you listen to the sound?
No.
No? No sound.
Are you comparing irrigation and rinsing?
Rinsing. No, I'm
Rinsing
not.
and irrigation.
No, I'm not comparing. I'm showing you how to irrigate. Let's see how's the irrigation being done in a proper irrigation, okay? Include sound. This is eye irrigation. Okay, eye irrigation for chemical eye injury.
Mistakes while also respecting the patient. Wash your hands and don PPE. You will need local anaesthetic drops, pH paper, speculum, towel, bowl, cotton buds, a jug, syringe, giving set, and clean irrigating fluid. Prepare all the equipment. Explain what you're going to do and gain consent. Lie the patient down or get them to lean back on a seat. Tilt the head to the side of the affected eye. Place a towel and bowl to soak up fluid. Put local anaesthetic drops into the eye. Remove any contact lenses. Use your fingers to open the eye. Pour fluid from a close distance using a jug or giving set. You can also keep the eyes open with a speculum and use a large syringe to irrigate. Ask the patient to look in different directions. Make sure you irrigate the lower fornix and evert the upper lid to wash away any foreign bodies. If foreign bodies remain, then use a cotton bud to remove until they're all gone. Continue this for at least 15 to 30 minutes. If litmus paper is available, then stop when the pH is neutral. If after irrigation there's a large corneal abrasion, the cornea looks hazy, or the conjunctival vessels are blanched, then refer to an eye specialist.
Okay, I'm going to do eye irrigation. The materials that you're going to need for eye irrigation are an irrigating solution, usually.
So that's
sitting in with us today. We'll get started with this presentation. As most of you had the same experience I did, that our exposure to eye problems in medical school was about 2 weeks.
Oh, I'm sorry. Just now I didn't unmute myself. Just now somebody asked for syringing, is it? Is it Stephen? Stephen asked about
I asked
syringing. Yeah,
syringing.
syringing is for lacrimal obstruction. It's basically different purposes. For urgent ocular care related to chemical injuries is irrigation. When you have a patient with chemical injuries or chemical splashings into the eyes, then you have to irrigate first before you can send them, or before waiting for the ambulance to come, or send them for emergency. Sorry?
Use water or use sterile water or use saline to rinse off the irrigation.
For irrigation, you can use saline.
Oh,
You
saline.
can use saline, yes. Because normal tap water, right? They are afraid of infections lah. Because the chemical might cause a perforation. So if tap water, then maybe we're afraid of bacteria to enter the cornea and cause different issue.
How much the water the used to do the irrigation is 1,000 ml or more 2,000?
Doesn't matter as long as you irrigate for 15 to 30 minutes.
Do we need to invert the eyelid to rinse or just pull up the eyelid to rinse?
You have to pull up the eyelid. Okay, just now you can either use your fingers to pull out lower and upper eyelid, or you use a speculum lah. The speculum is the instrument that helping the eyelid to open.
We automatically allowed to use the what spectrum.
Speculum, yeah. Yes.
How to pronounce spectrum?
Can already lah now, because we can use the anesthetic already, right? First we put the anesthetic, then we can put the speculum and open the eye. With the current optical act that will be happening soon, it should be all right. Okay? So I have another video that I would like you guys to see on the perspective of physicians, okay? Now what I am presenting for you guys is on the perspective of optometry. So of course, on the perspective of physician is in a different view, okay? And it's a half an hour YouTube video lah, okay? You can always, I would suggest you to watch now. If not, I don't think you can watch it anytime, right? Okay. But if you feel like you want to watch it later, also can. But for right now, I'm just going to show it to you guys. Okay.
Right after we finished our second year, when I was contacted to do this talk, I was really excited, and I put together this great talk with a big bunch of slides, and when I ran through it, it was about 2 hours long. So what I did is I cut this down to about the 13 most common things you may see in your office, and some things to look for as well. I'm trying to see if I can turn off the video to save some bandwidth. Yeah, I'm going to turn off my video because I'm out here in Shelby County. I don't know how my bandwidth is. So whenever we see an eye complaint, the first thing we always ask is the same common questions we ask for any medical problem. The eye's a little bit specific. The first thing we ask is, which eye is it in? Is it one or is it both? And if it's both, did it start in both? Always ask if a patient complains of loss of peripheral vision to make sure that it's not in both eyes, because sometimes they will say they have loss in the temporal field of one eye and they don't realize they have loss in the nasal field of the other eye because they just assume that it's their nose in the way. Ask about the quality of the complaint they have. If it's pain, is it sharp? Is it throbbing? Is it aching? If it's vision loss, is it complete or partial? What is the quality of the vision change? Is it foggy? Is it blurry? Are there spots? And in the redness, is it blotchy? Is it the total eye? When did it start? Is it intermittent or constant? If it's intermittent, how long are each individual episodes? Does it occur worse certain times of the day? What were you doing when it happened? Where were you when it happened? Have you been exposed to any recent chemicals or recent people who've been ill? Are you on any new medications? And of course, the age of the patient plays a big role as well. What have you done to treat it? And has it helped? And if you're in an emergency room setting and you put a drop of anesthetic in, you can ask them, did that help? And if the answer is yes, then it usually represents some form of surface issue and not necessarily anything worse. Are there any associations? So if you have pain, is there a change in vision? If the eye's red, is there discharge? Is there pain with change in vision? Are there flashes of light? Is there light sensitivity? So I want to go through some case studies, and I've separated into 3 sections. I'm going to start with red eyes first. So this is one that you may see, and it usually presents in both eyes. Generalized redness. It can be fairly mild to moderate. It could have started a few days ago or a little bit longer. They may have had a recent, exposure to someone who's been sick. There's a fair amount of discharge, and it's usually described as mucopurulent. There's usually no lymph node, pre-auricular lymph node, and that's the lymph node right in front of the ear. There may be some associated crusting on the lashes. There may be some inflammation of the lid. And you look at the patient, and this is what it looks like. If you were to take a Q-tip and wipe at that discharge, it would soak into the Q-tip. So it's more purulent than it is mucoid. This is bacterial conjunctivitis. You guys probably think you see this more than you actually do, because it is actually fairly uncommon. It's more common in people who have associated lid inflammation called blepharitis, and multiple pathogens are possible. Specifically, staph is the most common. The discharge, as I said, is usually more purulent and not as mucoid. So the treatment, you really don't have to do anything about this, believe it or not. The normal blinking mechanisms, the normal antibacterial properties of the tears will clear this on its own. But most of us do treat it with some broad spectrum antibiotic just to speed up the resolution. And, you know, we use things like ofloxacin, which is a fluoroquinolone. Polytrim works very well, especially in children. So that's where we go there. But don't forget about hyperacute conjunctivitis. And this is when there's a lot of discharge, and as soon as you wipe it away, you turn your head and you turn back and the discharge is recurred. They may have a lymph node with this, and this one is due to Neisseria, and usually it's gonococcus. If you have the capability to gram stain this, is really helpful to identify the gram-negative diplococci. If this is hyperacute conjunctivitis, this needs systemic treatment, not topical treatment. And that's what it kind of looks like. You can see the amount of ropey discharge. You can imagine, wipe that away, you turn back and there's more of it. This is the second case. This is one that's a little bit more common. Usually starts in one eye, may spread to both. The eye's red, it's irritated. There's mucoid discharge. Maybe a little bit of blurred vision, usually crusting in the morning. Usually there's some exposure. Oh yeah, my son had a red eye last week, or I was taking care of my niece who was coughing and sneezing. There may be a little associated light sensitivity, and there's usually a preauricular lymph node. If you feel by the ear, there is usually a knot or some tenderness there. And the patient comes into your office and they look like this. And you look at this eye and it's red and this discharge. Now, if you take this with the Q-tip and wipe the discharge there, instead of it sucking on with the Q-tip, it's more stringy, almost like mozzarella cheese on a pizza. It strings out. So this obviously is viral conjunctivitis. This is extremely common. There are multiple pathogens, adenovirus being the classic, but there are rhinoviruses that can cause this. There's coronaviruses that can cause this. The discharge is usually more mucoid than purulent, and this is extremely contagious. The treatment, this is self-limited. If you don't do anything, it will eventually go away. I always recommend strict hand washing to limit the spread. When I was in residency, you know, it was drilled into us that it was verboten to put people on steroids for viral conjunctivitis because it extends the disease. Unfortunately, in this day and age, people have to work, people have to function. And so I will occasionally put people on a short course of a mild topical steroid like loteprednol to help reduce the symptoms. It reduces the redness, it reduces the discharge. The same way when they come in with an upper respiratory viral infection, you recommend, you know, decongestants, you know, to help just get them through the symptoms. In children, I will often go ahead and put them on an antibiotic drop because kids tend to get secondary bacterial infections when simplex can sit out there. So the difference here is rather than discharge, the main symptom is the foreign body sensation and the light sensitivity. They may still have a lymph node because it is a viral infection. They may have had previous episodes. And the treatment is actually systemic medication works just as well as topical drops. There was a major study called the HEAD study that was published now about 20 years ago, the herpes eye disease study, that showed that systemic treatment with the antivirals, acyclovir being the one they used in the study, worked just as well as topical medication for this condition. And this, of course, is the classic herpetic dendrite that we see often. This one, case 3, is a pretty serious one. I hope you never see it, but I want you to make sure that you do recognize it. Unilateral, generalized redness, severe pain, severe blur, usually acute onset. This is usually an older patient, especially someone who has not had cataract surgery, somebody who's usually farsighted. So if you look at their glasses, they usually look like Coke bottles. They may have started a new medication recently, and I'll mention it to you in a minute. The associated symptoms of nausea and vomiting are fairly prominent. And if you look at their eye, their pupil doesn't seem to move very well. And you look at them and this is what it looks like. If you've never seen a mid-fixed dilated pupil, this is what a mid-fixed dilated pupil looks like. And if you look at the other side, the pupil will be much smaller. Also, I want you to notice, I'm going to see if I can get my pointer to work here. This is the slit beam of the slit lamp. The front of the cornea is the left side, the back of the cornea is the right side, and you notice there's no gap between the next step, which is the iris. When we usually look at people with a slit lamp, there's a fairly big gap between those two structures. Also, you notice this haziness here, which tells us that the cornea is swollen. This, of course, is angle closure glaucoma. This is due to an elevated pressure due to the narrowing of the anterior chamber. This is vision threatening. The systemic symptoms of nausea and vomiting can mask the ocular symptoms. And I have in my career at least twice been called up to the floor in the hospital because a patient got admitted for GI problems. And once they got up on the floor, the nurse looked and said, "Boy, your eye's really red." And then they called us. We found out that this patient was an angle closure glaucoma. Medication, specifically Topamax, has been reported to narrow the angle, especially in younger people. If you see somebody who's younger that you're worried about, ask them about this particular medication. Also, this is extremely unlikely if the patient has had cataract surgery. So if you try to call me about a 75-year-old who's an angle closure and ask them if they've had cataract surgery and you say yes, I'm going to tell you it's probably not angle closure. Cataract surgery opens up so much space that the likelihood of angle closure is almost zero after cataract surgery. These patients need emergent referral. We got to drop the pressure. Unfortunately, because the cornea is swollen, eye drops don't work great. So we use oral medications or IV medications, such as Diamox. Fixing the anatomic problems, the underlying solution to this, we'll do a peripheral iridotomy in the office, or ultimately cataract surgery may be the ultimate fix, but we just got to get them to our office to, or get them taken care of. All right, let's go to a little less severe case. So case 4, this is one you will see, we see this at least weekly. You may see it just as much. It's usually unilateral. Patient has no pain, maybe a little foreign body sensation. And what they describe the redness of their eyes being is a splotch of blood. It could be a small amount, it could be a large amount. It's usually acute onset. Most people notice it upon awakening or looking in the mirror the first thing in the morning. There may have been associated trauma with this. They may be on blood thinners or have high blood pressure. The biggest take home is there's no significant change in vision. And when you look at them, all right, and you've seen these before. Another example. Third example. This, of course, is a subconjunctival hemorrhage. This is a broken blood vessel on the surface of the eye. This is completely benign, completely self-limited, usually resolves over 7 to 10 days, a little bit longer if the patient's on an anticoagulant. The treatment is to basically reassure the patient, let them know this is just a bruise, it's going to go away. Over the next few days, gravity is going to let the blood kind of settle to the bottom of the eye. As the blood breaks down, it may turn a little yellow. If the eye's a little scratchy, use a little bit of artificial tears. As long as you've got them in their office, go ahead and check their blood pressure just to make sure it's not elevated. If you're suspicious, they're on Coumadin and you're suspicious just because they've had several of these in the last month, maybe check their anticoagulation just to make sure they're not overly anticoagulated. But most of the time, this is completely benign. But don't forget about retrobulbar hemorrhage. This is usually associated with trauma. The patient usually has proptosis. The big finding is they have decreased vision and reduction of eye movement. And if you have a way to check the pressure, they have an elevation of the pressure. This is vision threatening, and they need to get that pressure down either with medication, lateral canthotomy, which I know some of you guys in ER know how to do. I will occasionally, I've done this once in my career, take a little sterile needle and release some of the anterior aqueous humor to let the pressure down. And that's what this looks like. This is much different than what we just saw. This is a lot of hemorrhagic chemosis. The eye is proptotic. If you have the patient look around, they cannot move this eye, and this is an emergency. This is one that you also see fairly commonly. This is unilateral redness usually. There's pain, redness, light sensitivity, and a small amount of blur, possibly, maybe severe blur. They may have had a previous episode, and when you look, you'll notice that one pupil, the affected pupil, tends to be smaller than the other pupil. They may have some underlying rheumatologic disorder. They may have some floaters. And when you look, the redness of the eye is in this pattern. And if you guys have never seen ciliary flush, this is what ciliary flush looks like. The redness is focal around near the limbus, which is the transition zone between the cornea here and the sclera. So the redness tends to hang around the limbus here. So this is ciliary flush. This is another episode. And if you look down here at the very bottom of the picture, that is what we call a hypopyon. That is a collection of white blood cells in the inferior angle there. So this is iritis or uveitis. Uveitis is the broad term for inflammation of the pigmented parts of the eye, the iris being one of those. And so when it's the inflammation is in the front part of the eye, we call it iritis. And the severity is variable. Some people, it's very mild. Some people can barely walk into the office because it's bothering them so much. The treatment, steroids, topical is usually the start. Sometimes we'll use oral, and occasionally we use injectable either on the surface of the eye or into the eye. We usually do cycloplegia, especially at first, to help dilate the pupil. That helps with the pain control and also has an anti-inflammatory property. They may need an underlying workup for systemic disease. My usual rule of thumb, if somebody has one isolated case of iritis that goes away according to what I would expect and doesn't recur, I usually don't work them up. But if it recurs, I tend to work them up for an underlying rheumatologic disease. Also, if we think there's an infectious possibility, they may need aggressive antibiotics and surgery. This is especially true, the case I just showed you. This is actually a post-operative endophthalmitis. This person's had cataract surgery and they've got a post-operative infection, which is causing the inflammation. And they need aggressive antibiotic and surgical treatment. All right, we made it to the first third. The next section I want to talk about is complaints of decreased vision. I get called almost daily about this particular one. The patient calls, this is usually bilateral, but it may be more pronounced on one side than the other. It can be described as variable. It can be blind spots, it can be colored lights, it can be jagged lights, it could be prisms, it could be scotomas, it could be loss of hemifield. The severity is variable, and on average, it lasts 10 to 40 minutes. And it follows a crescendo decrescendo pattern, meaning it gets worse and then gets better. Females may be slightly more than males on this, and there can be some associated headache, nausea, maybe a previous history or a family history. And this is kind of a representation of that. If you look at the upper left, you see this little scotoma in the center that as time passes gets a little bit bigger, and then gently fades. This is a migraine type phenomenon, and this is extremely common. These may be purely ocular. I've told people they had a migraine and they say, I hadn't had a headache. And like, no, you can get an ocular migraine without a headache. They may also have a history of migraine headaches in the past. I get some older patients who come in, I had this visual disturbance. And I say, do you have migraines? And they say, yeah, when I was younger, I had migraine headaches horribly. Well, this is now your new variation of your migraines. And the usual triggers apply: stress, disrupted sleep, caffeine withdrawal. Also, don't forget about blood pressure fluctuations, especially, people, over 40, and especially as we get older. And it's usually a drop in blood pressure that can be a trigger. So either the blood pressure goes high and it drops back to normal, or they get a little dehydrated, or they sit around for too long and the blood pressure drops and they get this trigger of a migraine. If this is recurrent or worsening, they may need further workup, including an MRI. And if a person has their first episode and you're convinced it's their first episode, I'm never opposed to getting an MRI just to make sure there's not a structural lesion. But most of the time, the MRIs are negative. But don't forget, if it's only in one eye, and you're convinced that it's only one, the patient's convinced it's only in one eye, and it lasts, instead of 10 to 40 minutes, 10 to 30 seconds or a couple of minutes, then we call it amaurosis fugax. And there's a high risk for impending stroke with this. So if they have this, then they need a carotid Doppler or CTA, possibly an echo. And if we get them in the office and we examine them, we may be able to see a small embolus in one of the arterioles, because the amaurosis is an embolic event. Second case, usually female, younger, graying of the vision. Severity is variable. It could be just a little blurry, or it could be, I can't see anything. There may be some associated pain with eye movement. And when you look, the optic nerve may look like this. It may be a little swollen, or it may look normal. This is optic neuritis. This is due to an inflammation of the optic nerve. As I said, the optic nerve may look a little swollen or hyperemic, or it may look completely normal. There is usually a relative afferent pupillary defect present. This is sometimes difficult to pick up on. Those who don't look for it every day, sometimes it's difficult to see an APD. Even our technicians who do this for a living have trouble picking up on an APD. The one test that I found that's pretty helpful for this is red desaturation. I will pick up our dilating drops, which have a bright red cap. I'll ask them to cover the eye that's affected and look at the red cap against my white lab coat. And then I have them look with the eye that's affected and I ask them, is this as red in this eye as it was in the other eye? And I'm actually very surprised how quickly they say, no, that's not nearly as red. It's much less red. And that's usually a sign of something going on with the optic nerve. As you know, there's a high association of optic neuritis and MS, especially in young women. So look for other neurologic findings. This can also occur after a post-viral illness. I've certainly seen that. If you've got suspicion, you got to get an MRI. MRI of the brain, looking for MS-type lesions. If the onset is recent and the MRI is positive, then IV steroids can be helpful, and getting neurology involved can be helpful. The IV steroids speed up the resolution of the problem, but they do not change the long-term outcome. If the MRI is negative, there's really no indication for steroids. So this is the classic MS picture. The upper left corner shows a relatively normal optic nerve. So this is retrobulbar optic neuritis. The upper right shows a visual field with a central scotoma. The lower left shows the MRI with enhancement of that optic nerve. And then, of course, the lower right shows the white matter lesions consistent with MS. Case 3 is a similar type of vision change, but this is usually an older population. This is males equal to females. They usually have some vascular issues such as hypertension, diabetes. The vision loss in this is tends to be more a hemifield loss, altitudinal loss. And when you look at the optic nerve, it looks like this. It's swollen, and you don't look at optic nerves, but that one's pale. It's much less color. This is ischemic optic neuropathy. This is usually an older population. This is due to vascular issues. The visual field loss is usually described as altitudinal, meaning it usually affects the upper or lower half of the vision, the upper half being the more common. There is usually an afferent pupillary defect. The treatment is to treat the underlying vascular issues. The vision loss is more than likely permanent, but you want to prevent a similar event in the other eye or to prevent a stroke. So they need a vascular workup. And don't forget about giant cell arteritis. So anybody who's got this needs a stat sed rate and C-reactive protein. Also ask about the usual symptoms of GCA. Look for, ask about headache, weight loss. Does your jaw hurt when you eat? Does it hurt to comb your hair? The usual things. If you're suspicious enough for giant cell arteritis, go ahead and start them on the steroids. Start them at 80 to 100 milligrams of prednisone, and then let us sort it out later. If we can get a temporal artery biopsy within 2 weeks, it's still valid. As some of you know, Actemra came out, and it's an anti-interleukin-6 medicine, which can be used in place of steroids, but usually we start with the steroids and then transition to the Actemra as we can. If you've never seen a temporal artery biopsy, this is what it looks like. We try to get about 1 to 2 centimeter piece of the superficial temporal artery and look for inflammation of the artery. All right, here's another very common one that I get called from the ER all the time about. This is unilateral. It's black spots or strings in the vision. They seem to move without movement. It may be described as a cobweb. Usually the patient is over 50. There are flashes possibly associated, but no pain and no significant loss of vision. And this, if you've never experienced this, this is kind of what it looks like from the patient's point of view, they've got this thing floating in their vision. And if you look, sometimes, and this picture kind of shows how hard it is sometimes to see it, there may be a little condensation within the vitreous gel that you can see. This is a posterior vitreous detachment. This is the normal age-related deterioration of the vitreous gel. When this occurs acutely, there is an increased risk for retinal detachment and retinal tear. And that's especially true if the patient's a high myope or if there was trauma that triggered this. And in this situation, the recommendation is to try to get them in for a dilated fundus exam in our office where we can lay them back and look all the way out to the edge of the retina within about 48 hours. So close observation. If we identify a retinal tear, that can be treated in the office with laser, but if it evolves into a retinal detachment, it requires surgery. I always tell the patients this is true, that the floaters are permanent, but they do become less bothersome over time. What, of course, you're watching out for is a retinal detachment. So if a patient presents with a vitreous separation, vitreous detachment, make sure you check their peripheral vision very well. If they can see all their peripheral vision, it is unlikely that they've got a retinal detachment. The patient may report that they've lost peripheral vision. And if this is the case, they need urgent referral, especially if the central vision is good. We would like to fix the retinal detachment before the macula becomes detached, because once the macula becomes detached, the likelihood of normal visual recovery after retinal detachment surgery is much lower. And that's what a large retinal tear looks like. And so that's basically what we're watching for. All right, we're doing well. I've got one more section to go. We're going to talk about eye pain. So this is a very common one from the emergency room, unilateral foreign body sensation with redness. There was a recent work exposure. You may not see anything when you look in other than maybe an abrasion on the cornea that's vertical. And you look in there, you may see this, which is a classic corneal foreign body. There's usually a work history, working under a car. But the other thing to remember is if you don't see anything, but you do see that vertical corneal abrasion, don't forget to flip the lid, because there may be a foreign body hiding under the lid that's scratching against the cornea. The treatment, of course, is removal of the foreign body. Usually we do use some prophylactic antibiotics and anti-inflammatory drops to help reduce pain. If you can't get all of the foreign body out, don't keep digging, because it is often easier to get the foreign body out after a couple of days. So get what you can get out, put them on drops, and then have them follow up with this in the next day or two. Don't forget to look out for penetration, intraocular foreign body or perforation. And this is where the history comes into play. If they have a history of grinding or other high-speed injury and they didn't have their safety glasses on, you need to look for an intraocular foreign body. This may be asymptomatic, but if you identify it, put a shield over the eye and get them where it can be taken care of. And the CT here shows an intraocular foreign body. And this shows something more severe. I remember when I first started, I got a call from the ER. Yeah, I've got this guy, he was in the backseat of a car and the window got shattered. And he got some glass in his eye, but I think he looks good. I think he's got a corneal abrasion. It's a little irritated, but his vision is normal. Oh, by the way, his pupil's not round. And I went, oh, get him in right now. And this is kind of what he looked like.
Email your presentation to yourself.
All right. Case 2. This is unilateral pain, foreign body, blur. Can be moderate to moderately severe, usually acute onset. Due to trauma, and the patient may say, oh, it's much better if I close my eye. And it looks like this. And you put a little fluorescein in, and it looks like that. So this is the classic corneal abrasion. You guys see these all the time. It's damage to the corneal epithelium. They almost always are a result of trauma. Should be completely evident with fluorescein staining. If they have a sharp type of injury, either a fingernail or edge of a piece of paper, it does increase the risk of what we call a corneal erosion. This usually heals without anything, but we always do use topical antibiotics to prevent infection. And the other thing we use is topical non-steroidal, specifically one that's easy to get is ketorolac. That's very helpful for the pain. Occasionally patching or bandage contact lenses can be helpful. A tetanus shot is not needed for this. But don't forget about corneal ulcers. And this is where that becomes infected. This is especially true in contact lens wearers. And the most common, of course, is bacterial. And if you cannot, for some reason, get a hold of one of us and you're suspicious of a corneal ulcer, just start the patient on a broad spectrum antibiotic like ofloxacin or Polytrim and put a drop in every hour until they can get in to see an eye doctor. And that's what this looks like. See that white infiltrate instead of the corneal abrasion. And here's a more serious looking one that's fairly advanced. Also watch out for topical anesthetic abuse. I know in the emergency literature, it says it's okay to use topical anesthetics. That may be true for a real short period of time, but I would not recommend it because people have a tendency to abuse these things. They get a bottle of topical anesthetic, they will keep using it and keep using it until their eye looks like that. So don't forget, if the patient keeps coming back to your office complaining of pain and irritation after having a corneal abrasion, ask them what drops they're using, ask to see those drops, and make sure that they don't have topical anesthetics. The non-steroidal drops like ketorolac work better than the topical anesthetics for this, and they do not inhibit healing. A couple more to go, and we're almost done. So this is a unilateral lid nodule. This can happen in children. Usually there is some discharge, and the patient comes in and looks like this. Well, this is a stop. This is a hordeolum. This is an infection of one of the meibomian glands. If it is chronic, it changes name. We call it a chalazion when it's chronic. In the acute setting, there's an active infection. In the chronic, it's more of a granuloma, and it tends to be non-tender. The treatment, we always start with warm compresses. We usually use a antibiotic steroid combination like Tobradex or Xylet or Maxitrol to help treat this. They may need incision and drainage if it persists, or sometimes a steroid injection into the lesion. But dicrocystitis can look like this. This is an infection of the nasal lacrimal sac, and it's usually due to a blocked nasal lacrimal duct. You can get, sometimes if you push against this nodule, you'll get reflux through the punctum. This needs systemic treatment, and usually we'll start with augmentin if the patient's not penicillin allergic, and they may need IV antibiotics if that doesn't work, and they may need surgical correction if that doesn't work. So this is what dicrocystitis looks like, and it looks pretty similar to a STI, but its location, it's nasal, it's not in the lid itself. And in some children, it actually can appear above on the upper lid. But again, this is dicrocystitis. Last case. This one we also get called about quite a bit from the ER. This is usually unilateral, involves one or both lids, redness, swelling, timing is variable. They may have had a recent STI or a bug bite, and there's no change in vision. And they look like this. The take-home message I want you to take is that look at the white of the eye. That eye is white. This is preseptal cellulitis. This is an infection that does not extend posteriorly. This is not an emergency. It may be related to a recent STI. It does not need admission or IV antibiotics. It may not even need oral antibiotics if it's due to a STI, but treat it like any other skin infection, and warm compresses can help. But don't forget about shingles. Sometimes the rash can show up, the redness and swelling can show up before the rash. And you guys know to treat this with systemic antivirals. If it involves the eye, topical antivirals don't play a role here. We treat it with steroids. And then the very last thing I want to, and this is what, of course, shingles looks like. And I know I'm running low on time. So the last thing I want to talk about is the worry you guys always have is orbital cellulitis. This is an infection in the orbit. This almost always involves sinus disease. This almost never comes from the skin side. So if they've got a STI, they're not going to get orbital cellulitis. But this is vision threatening. The key is what the eyeball looks like. And so this is a patient with orbital cellulitis. If you look at the eyeball on the left side, you notice how red it is, it's proptotic. And in the lower picture, the patient is looking up while the other eye is not moving. And that's really the key. When this involves the orbit, it causes proptosis, lack of motion. So this is the emergency. This is completely different than preseptal cellulitis. I think we made it.
Thank you, Brennan. I certainly think that I learned more during that 30-minute talk than I did during the 2 weeks in medical school on ophthalmology. So thank you.
Okay, so I hope that's enough. Any question that you would like to ask before we end the lecture today?
Yes, I heard next week we're gonna have a tutorial. How's the
Yes.
tutorial gonna carry out?
Okay, the tutorial is going to be a discussion. So basically everyone need to be involved lah. So I'm going to present a case study and you guys need to basically discuss, maybe in group, maybe in individual. We'll see how it goes. Okay, and then we're also going to answer some quizzes. Okay, it's all online and interactive lah. We try to do it as simple as we can, but the take-home message have to be there. Is that all right?
Okay.
Okay, so I hope that next week for tutorial, everyone can get involved. Everyone can be interactive. If you have any question, you can also ask during that session, okay?
Okay.
Okay, I think that's all. So we'll see you next week, 3 o'clock, 3 to 5, okay? Bye-bye. Have a good day.
Bye. Thank you, Mr. Lee.
All right, welcome. Bye-bye.